I'm not here to tell people how to run their business models, right? I'm not here to say what is the best, what is not, right? But I will tell you this. This conversation always happens whenever I talk to digital health companies that want to get into the MSK space, right? And they're convinced that, like, if I give you the fanciest gadget and the coolest camera, and I have the best looking models, right, with skimpy clothes on, and they're doing the exercises, that you will then look at it and you will do all the exercises, and the camera will tell you when you're wrong and you'll correct it. My stance is this: if that would work, our profession would not exist. Because there is nothing I ever tell a patient that they can't get from Google. There is no exercise, no strategy that is not available free out there for them if they search hard enough. They come to a professional for your professional insight, for your decision making on what is the best way for them to move forward.
This is The Direct Path, a show about the future of MSK care and the people who are bold enough to build it. Join us weekly as we talk with innovators who are challenging the status quo. Here's your host, Scott Hebert.
Hello and welcome to this episode of the Direct Path podcast. Today, we are joined with one of my favorite people in physical therapy, Drew Contreras. Drew is VP of Strategic Affairs over at APTA. Before that, a distinguished career in the Army, and then a career treating some of the nation's top leaders. Boy, does Drew have some amazing stories, some of which I'm sure we will get into today. But Drew, so glad to have you on the pod today. Thanks for joining us.
Yeah, thanks for having me. I'm looking forward to it.
Awesome. Well, I'd love to start off kind of a little bit with your background, how you became a PT, how you ultimately decided to be involved in APTA. Why don't we kind of give the folks at home kind of your story?
Yeah, right. So, I think I have a pretty standard kind of background. Grew up as a football player in Ohio, got myself hurt, right? Went to PT. My PT, some dude who stood around in a polo shirt and warm-up pants with one hand in his pocket and a coffee cup in his other hand and just screamed at me to do more squats. And I thought, this is the greatest career in the world. I need to do this. So, right, that was my, what is this profession? Then, I went to college on an ROTC scholarship. I then went to graduate school. I got my master's in PT at Gannon University in Erie, Pennsylvania. And then I came on active duty in the Army as a physical therapist. I started my kind of career in Fort Benning, Georgia, kind of working with initial entry training. So basic trainee soldiers. Started working with some of the other higher level tier 1 units that are in that area. Then my career kind of progressed. I went over to Fort Bragg, North Carolina. Amazing opportunity to work with some of the, the special forces groups. And then I wound up working with the 82nd Airborne. I went on a glorious 15-month deployment to Iraq with the 82nd Airborne. Was first physical therapist to serve that role with the again, and that's really where I kind of more or less honed my absolute craft of being like a primary care MSK clinician, which is really what the PTs are in the DoD. Is you're really just a non-surgical orthopedic surgeon, more or less, right? So did that. And then after I kind of came back from there, the Army decided that I was a pretty good clinician, but I wasn't a super great officer. So they sent me to charm school at the Pentagon to learn how to wear a clean uniform, do that officer kind of thing. And while I was there, I got asked to cover down on the White House. So the White House is just across the river from the Pentagon. There was a massive influx of middle-aged men with patella tendon, Achilles tendon, and ACL ruptures because it's 2010 and everybody's trying to play basketball with President Obama, and it wasn't going well for a lot of these guys. So I wound up literally having a sports med clinic with all these injured people, which then turned into me having more a sustained role over there and eventually being named the physical therapist to the White House. Stayed over there till the end of the Obama administration, till 17. Finished out my military career, working on some other projects and things for the military with the H2F program and some other stuff. And then I retired. And after I retired, I was kind of just hanging around trying to figure out what I wanted to be when I grew up. And APTA reached out to me and they said, hey, man, we heard you're kind of sitting around. Maybe you're, looking for stuff to do. Right? And my response was, I don't know. I'm busy fishing. I'm not really, I don't know. I don't know about you guys. I don't know that you're a good fit for me. And my answer to that was I'm a clinician. That's all I've been. I wasn't an academics. I wasn't this, big proponent, or I didn't, do all the advocacy things, right? I'd done some stuff with the federal section, but I was a clinician. And I said, I don't know that the APTA's focus is where I want to be, right? Which prompted a conversation with me and the CEO, Justin Moore. And he was like, what do you mean? And I said, look, like, I think that the APTA needs to focus more on just people who see patients, like people who are doing the work. Like, I get all the other stuff's important. I understand advocacy, payment, all those things have to be done, right? But you need to be more relevant to the people who are just seeing patients. And the invitation I got was to come on board on staff and help with that. So that's been about 5 years now that I've been here, and trying to kind of nudge those things, and in different ways have kind of found myself involved in some of the things that are moving practice in the direction it's going.
Such a cool experience on so many levels. And again, thank you for your service both to the country and to our profession. It's pretty incredible. We think of physical therapy so often. We think of ourselves as the little guy. We think of ourselves as this kind of like ancillary profession. I think allied health or
Hell,
it's this kind of little narrow niche, but there you were sitting in the White House treating the leaders of the free world. What did you feel, or what was the sense you got from these individuals, the folks at the peak of power, how they viewed physical therapy?
So I'll share an insight with you. But there was a point at which I'm coming in there and I'm just doing my thing, right? I'm treating everybody from the electricians and the maintenance workers up to the president, everybody and everywhere in between, right? And what you kind of start to understand in kind of that environment is like, it's kind of like a team where there's not that deep of a bench. One videographer, there's like one main speechwriter, like they kind of need these people, right? So if they go down or they're not available, like it's a problem, right? So you really kind of fill this role of, you're really in that role, the best asset to help provide healthcare that doesn't use narcotics, right? That doesn't require all kinds of over-the-top medical pills, potions, and procedures, right? So you really sit in that crux where you can be helpful. You can help people manage, get through, mitigate whatever their conditions are, and still be useful, right? So it's one of those things where, small success begets more success, which then you end up being there full time. And that's just kind of how it was, right? Like, the one thing that's really funny about that place, right, is it's not really about cost, right? As you can imagine, right? It's not really about like, should we have this type of provider? What it's about is efficiency, is what is the most efficient thing that I can leverage in these problems to get me where I need to be? Because the most relevant asset that any of them have over there is time. Time is limited, right? They only have so much time. They're never going to get more time in that office or in those positions. So anything you can do to keep the time, keep things on schedule is important. And that's where PT really kind of fits into that mold.
Yeah, and totally mirrors, I imagine, your experience in the Army, where we talk a lot about the kind of the role of physical therapy in a primary care position. That's the whole idea of going direct. This is not a new concept for the U.S. military.
No, right. This is the concept that really kind of took root in the late 70s, solidified itself in the 80s, and since then has like just kind of been the practice model that makes the most sense, right? When you have a PT that can really see from initial injury all the way through to discharge and manage a non-surgical problem, like, you're offloading a ton of things from the system, right? You can decide, does it need imaging? Do we need to order that? And if I am going to order it, what do we do with it afterwards, right? You can decide, well, you know what? This really needs to see this subspecialty, so I need to refer them over here to this. Or you can make the decision of like, this is not something that we need to spend a lot of time and energy on, right? I can help you along this pathway with these interventions, but it also requires the physical therapist, right, to kind of assume that doctoring level, to be the provider, kind of the apex of that non-surgical MSK stuff, to allow the rest of the team, whether it's PTAs, medics, techs, or whoever it is that's in your kind of hierarchy where you're at, to take care of the rest of the patient encounter, the rest of the things that need to be done, the rehab, the progression, regression stuff that you need to do, and allows the PT to really focus on the diagnosis, the determining the plan of care, determining what the needs are of that patient, very much in that primary care role.
Love it. Love it. Yeah. And I mean, that's talk about practicing at the top of your license, right? I mean, this is the key that I think so many folks are kind of yearning for. It's great to see a system that incentivizes that behavior.
Yeah, and the thing about it is, right, kind of the thing that I think the most value you get in it is when you're in kind of that system, like in the DoD, where, like I said, like I was assigned to a unit. And I went with the unit, wherever the unit's job was, I was there. And what you start to understand is when you become in a primary care role, like those are your patients no matter what, right? So like if you, oh yeah, I did some whiz bang stuff and I made your symptoms better for a day and they go away, it's going to come back and they're going to come back and it's still your problem, right? So very much like if you're working with an employer and it's that employee, right? Like it's still your patient. So you are incentivized to do the best you can to keep them healthy, to keep them going so that they can do whatever it is they need to do, because they're just going to come back to you if you're just kind of not putting forth the attention and detail that it deserves.
It's such a good point. As you kind of transitioned into your role at APTA, kind of came back into private sector world and then ultimately had a very interesting viewpoint, especially as, somebody thinking about things from the national organization standpoint. One of my favorite things about you is you've never been afraid to give the profession a little kick in the ass where it needed it. And I imagine, you were kind of working in this highly efficient, focused model, and now you're entering into this world where, as an industry, we've experienced a lot of change, but I think we've also seen a lot of hesitancy to change. Your role is from an innovation standpoint. Where are you feeling like as an industry we just are getting stuck in the mud and having the hardest time, evolving?
That's a good conversation, right? Because so I came from this world where it was really about being in your highest and best use, right? And then to be blunt, right? Like I knew there were some people mailing it in the profession. We all know it. We know that there's some people that are like checking the box. Yeah, 3 sets of 10, do these things on the sheet and blah, blah, blah. But what I failed to understand is that there are some systems in place that want you to stay there. And I didn't understand that. When I talk to clinicians and they're like, well, it's most important that I get somebody in for 12 visits. And I'm like, what are you doing for 12 visits? What if you're done in 4? Well, we keep doing the plan of care. I'm like, but they're better. Like, if you've reached the goals, what are we doing? Well, I'm like, I get it. Like the business model is overtaking your clinical decision making. And I'm not here to pass judgment on that. I'm not here to say what it is. But what I am here to say is if you're really focusing at your highest and best use in that role, your goal is to get to the patient's goals. It's not to get to a imaginary revenue cycle. And I know that's easy for me to say, right? Because I'm not the one who has to pay the bills or make the salaries or pay the rent. I understand that. I understand all of that. But what I don't understand is if I took that model and I said, okay, look, I got you better in 4 visits. Well, now I can get somebody else in. And now I can do another evaluation. And in fact, I can do 3 of them instead of 1 over these 12 visits. How does that not work better? How is that not a good thing? How is it not better if I leverage my PTAs to allow them to work at their highest use so that I can continue to do the other things? And what I did not understand was that for a lot of PTs, it's uncomfortable to be put into that role, right? They're not super comfortable being in that the buck stops with you role. And that is our biggest shortcoming, is the lack of people understanding that the truth is, like, it was always your responsibility, right?
Oh.
Like you were always on the hook for it.
Yep.
But now you feel like you are, right? But you just felt like, oh, I'm just doing clamshells, right? Like, no, you were always on the hook. If you misdiagnosed, if you did something wrong, it was always your problem. But now it's staring at you in the face repeatedly, day after day. So I think that, as we move to a doctoring profession, right? If we had that, and I hear it all the time, we became doctors and nothing's changed. I would say, like, no, I don't think that that's true. But I think that the lagging of the accepting what that means to have that title and what it means to take that position as a profession has been the thing that we've been stuck in the mud the most over.
Totally agree. It's interesting. I was having a conversation with a friend earlier this week, and we were talking about this idea that there is no mission without a margin, and the fact that there are just practical realities in building a therapy business, but balancing those is hard. And what became abundantly clear was that ultimately, at the end of the day, there's this invisible hand that's moving all sorts of strategy decisions, especially in a practice model. Unfortunately, that hand almost always is who's paying the bills, right? And in the traditional outpatient world, we're doing so much because insurance companies are dictating that we do it a certain way. And so it's been really, interesting to see that. At the same time, and this will maybe be a good segue into the next part of our convo, I have a lot of friends who are in the digital health world, right? Who basically exclusively treat telehealth or work at a digital MSK company. They have an invisible hand that moves them too, right?
Yes,
Which is their business model, which is incentivizing a whole new set of things, right? Which creates its own challenges too. And so no pathway is perfect, but the closer that we can align folks to the value that they provide and the individual who's receiving that value and ideally paying for that value, the better alignment you start to have to look a lot more like the model you described.
Yeah, right. And like you said, it really comes down to the value proposition. What are you providing? What is that worth? And how does everybody get the best out of that, right? And if we're gonna have an honest conversation, we need to talk that like the fee for service model, right, is probably near the end of its life cycle, right? It's too easy to just year after year cut it, because then if you're not willing to look at what does the next cycle look like, what does the next model step up into, then you will be relegated to whatever's left over at the end, right? And that's just like you said, those are the hands that are moving the things, and that's a real force in how this is going to move.
I think APTA unfairly, I think there's a criticism of APTA often that it's not focusing enough around a payment policy. But I know for sure, because you and I have had this conversation, right? I remember one of the first times we ever spoke, I asked you a question. I said, look, I see two trend lines about to intersect, right? I see reimbursement going stagnant or declining, and I see costs continuing to rise.
Yes.
What are we going to do about it? And how long do we have? I'm curious if that was a few years ago. I'm curious now if your perspective, on that has changed. How long do you think we have? And what do you or more broadly APTA feel like the logical kind of pathway needs to look like?
Yeah, I think that, right, I don't know, I don't have the number in front of me, right? I'm not going to sit here and say it's going to be, 3.7 years or whatever. I don't know, right? There's smarter people than me that do that. But I will tell you this, that there's no world where that model that was stood up in the early 80s is going to continue, right? Is there any business model that was set up 50 years ago that is still, right? Name them all, right? Sears, Blockbuster, name all of them, right? They've all since collapsed and moved on, right? And so if a professional model is not willing to pivot, i.e. Netflix, right? Hey, it's changing. Let's pivot the model. Let's do something different, right? This is the same thing that every mom and pop restaurant during COVID was I guess I have to do delivery and takeout now if I want to live, right? And those that did made it through, and those who were no, I'm not going to do it, don't, and you'll see what happens, right? So I think that right now, right, APTA is working on exploring what do all these things look like: value-based care, alternative payment models, all those sorts of things. And the reality is, here's the dirty secret, is this is not just a PT problem. This is a healthcare system problem. And there are lots of other entities interested in this as well. Nurses are interested in it, nurse practitioners, physicians, the AMA, lots of people are trying to figure this out. And if it was easy, it would have been figured out, right? It's not easy. It's complicated and it's messy, but APTA provides the voice of the profession. And if you aren't sitting at the table when the AMA RUC committee is sitting there making decisions, if you're not there having conversations, with CMS, you're not in the discussion, and PT is in the discussion. Now I get it, especially for all the private practitioners listening, are oh, but I still got 3% cut. Yeah, you did, and you got a 3% cut on your lowest reimbursable codes. But nobody does say is hey, thanks for that 1.7% increase in evaluation codes that I got. The most expensive thing that I bill for, we don't talk about that. I understand. I get it. I totally understand the math that, it's the revenue cycle and all those things, but you have to understand that, like, this is the narrative can be there that, like, you're right, there's cuts that are happening, but there are also wins and conversations that are going on. And I'm not naive and stupid enough to sit here and say that APTA's got everything right, because that is absolutely not true. APTA is in there doing what it can, fighting the fight, but it's messy. And if you think otherwise, I invite you to come on down, come meet with your legislators, come talk to our team and get involved.
Yeah. Well, I think it's so true that the importance of needing to have a seat at the table, and I think that there is so much uncertainty. That's the exciting part of dynamic markets, and especially times that feel challenging. The exciting part is something's going to change, and really, you have to be able to get involved and be at the table. One of the areas that we've had a lot of discussions about, and I think is near and dear to the hearts of folks that are likely listening to this podcast, is APTA's stance on digital MSK companies, especially when they came to the forefront. I know you were involved in a lot of this. What is APTA's position, and also feel free. I'm obviously your own position too. I'm sure that they're correlated to a certain extent.
They're very similar, as you can imagine, right? APTA's stance on it really just sums up like this. APTA does not believe that digital MSK is going to replace in-person physical therapy. However, I fully believe that a digitally enabled clinician, one who understands digital healthcare, one who understands how to leverage digital healthcare tools, will 100% replace a clinician who does not. And that, I think, goes for all of healthcare. If you are a clinician and you don't know how to start to leverage all the amazing tools that are coming out, whether it's ambient scribing, AI, blah, 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 all the fancy things that are coming, if you can't comprehend what those mean, you will be left behind. It is the biggest jump in technology in our lifetime, and we're not even hitting on the hard upward slope, right? We're just past the initial adoption phase. When we get to the peak of this, most innovation curves say that this is probably about another 5 to 10 years till we kind of hit the peak of it. That's when, if you have not paid attention, you will no longer be relevant, right? And I firmly believe that. So APTA's take on this is kind of the same thing with advocacy, is you must have a seat at the table. We must be talking about it. We must be engaged with those companies. We must be doing things that are providing a voice to the profession if you want to be included and be relevant. And that's kind of how we started off on it and why we started doing some of the initiatives that we did.
Yeah. Yeah. And I know APTA has taken a fantastic position, especially with the, digital health transparency pledge,
Yes.
In terms of really putting a foot down to do what I think is the most important thing for APTA to do, which is title protection, right? Which is to say, we all stand to be transparent about, if we're going to call it physical therapy, it better damn well be provided by a physical therapist.
Correct. Right. And that's one of the main things that an association does, is term and title protection. Right. We had this fight in the 90s with chiropractors. Right. Chiropractors are not physical therapists and cannot bill for physical therapy because you are not a physical therapist. Period. That has been settled over and over again. The same thing with the digital companies. It's just another entity saying we provide physical therapy. Not if you're not a PT or a PTA. You do not. And that has been settled and that has been proven. And look, we had to be fully transparent to the audience, right? APTA came out with this pledge because we knew there were companies trying to skirt this. And when it became apparent that some of the companies were, we had polite legal conversations with them that, like, you need to cease and desist because you're saying this, and here's the statute and here's the law, and we're happy to take this to litigation. We think that there's a better way forward than not without having to do that, right? And companies, once you kind of present that to them, realize, I'm sure they talked to their counsel and said, yeah, you're not going to win this one, right? And there were other companies that we worked with that have then since pivoted and have gone in a different direction, right? And we're not interested in working with those companies because, again, we're here for the physical therapy profession. I'm not here for the broad exercise industry. I'm not here for the health coach industry. I'm here for the physical therapy industry.
Yeah, and I think it's been interesting. I've followed Hinge for a very long time, and this is not intended to be a knock Hinge in any way. I've been on record saying I think they're a fantastic company, but as somebody who's followed them for a decade, things they used to call physical therapy, they now call exercise therapy, right? And I imagine that's in no short part to the work that APT has done to advocate, right?
And look, right, like I'm not here to tell people how to run their business models, right? I'm not here to say what is the best, what is not, right? But I will tell you this. This conversation always happens whenever I talk to digital health companies that want to get into the MSK space, right? And they're convinced that like, oh, if I give you the fanciest gadget and the coolest camera and I have the best looking models, right, with skimpy clothes on and they're doing the exercises, that you will then look at it and you will do all the exercises and the camera will tell you when you're wrong and you'll correct it. My stance is this. If that would work, our profession would not exist because there is nothing I ever tell a patient that they can't get from Google. There is no exercise, no strategy that is not available free out there for them if they search hard enough. They come to a professional for your professional insight, for your decision making on what is the best way for them to move forward. Physical therapy is a profession of humans on humans, and it's always going to have a human element to it. Now, having said that, I firmly believe that you can leverage all these things that we're talking about, right? And you can have a better patient experience, that I can extend my reach as a clinician by leveraging these tools. Absolutely. But if you think that you can just remove the clinician from it, feel free, go for it. I'm happy to watch it, to applaud your exercise education. Everybody should exercise. Everybody should move. But if you're, like you said, if you're going to call it physical therapy, there better be a clinician with a license behind it.
Now, I know one area that, again, I think there were some folks that were upset. I didn't totally understand being upset at the time, but I guess I can empathize because I think there's a lot of fear in the profession. When APTA partnered with Sword, I think a lot of people felt threatened by that.
Yeah, they sure did.
We talked about that a number of times. One, I'd be curious your thoughts. Like at the time, at the thinking, like, one, why was that the right move for APTA? And I know APTA has since moved on from that partnership. What do you feel like has changed in the market that put you in a position to decide that was no longer in the best interest?
I think that, right, like I said earlier, it was very clear, right, that digital MSK solutions were coming into the space and they were not going away, right? The valuation, the money behind it, and the amount of talented clinicians that they were taking to work for them is really what caught my eye, right? When you're selecting clinicians with 7 to 10 years of clinical experience, dual board certifications, fellowship trained, like you're taking no crap clinicians, like you're taking people who are to work for you. You have my attention now, right? And so that was my first standpoints of looking at it and saying, like, they're not just looking for somebody to check a box, like they're looking for people who know what they're doing, right? And having been one of those clinicians and been in a situation where I've used telehealth, where I've used, digital health before it was kind of mainstream because I had access to these things in the places that I worked and the locations I was at, I knew it's a powerful tool. And we needed to be in those conversations. And the conversations were great as we were everybody was figuring this out. It was really interesting to me when I would have conversations with people and I start explaining the actual tactical things on the ground of like, you have to have a license in the state where you're practicing. And people would be like, well, what do you mean? Like, no, if you're seeing a patient in Florida, you need a Florida license. What? Like, oh, you don't understand the profession. And this is where like the conversation started happening and realizing that like I needed to make sure that my members who were working in these places understood the roles and responsibilities and the limitations so that public health and safety was being adhered to, that term and title protection was all in place. And that was the whole onus of working on it. And you're right. There were a lot of people that were really threatened. I mean, I got personal conversations, emails like, oh my gosh, Drew's a knucklehead. He's selling out the profession. It's, you can't possibly do it. The only way you can do physical therapy is me one-on-one for 60 minutes in a strip mall clinic on a plinth with my hands on them. And I firmly do not subscribe to that, right? That has been shown to not only not be true with
Yep.
empirical evidence, right?
Yep.
It's just a bias that our profession made up, right? But to the point I always come back to was, yes, the clinician needs to be involved in the plan of care. And when companies decided that you didn't need clinicians to be involved in a plan of care, that's when I start to we're diverging on our goals and what we're working on. And then that's not a place that I need to be working with then.
Yep. No, I one appreciate the openness to the criticism. You've always been so good at at being totally fine with it. But also, I think it's a very positive sign to show that at the end of the day, I think the APTA is seeing it right, which is we're not trying to protect a singular delivery mechanism of care. We're trying to protect the profession, right? And that's what at the end of the day it really is the national organization's job. What is most important. So it's great to see that that's being done.
And that's like you said, that's really what it comes down to.
So, final question here, crystal ball, we're looking into the future. We've got these futurists among us in the profession that say the future is going to be completely out of network. It's going to be fully digital. We'll barely ever get our hands on the patient. We've got, meanwhile, stalwarts and folks that are terrified to do it who say, we're not going to change it all. It'll be exactly the way it is now. Drew, as somebody whose job is to kind of see the future and look to where the industry is headed, at the end of the day, where do you see, what do you see physical therapy looking like over the next 10, 20?
So 30? What's funny is think that what you're probably going to see already exists in parallel professions, where some aspects of the encounter are 100% covered. Some aspects are not covered. Some aspects of the encounter are at your discretion if you choose to do it. And here's a wonderful example, right? I go to get glasses. My exam's covered. Well, I would like this pair of glasses. Well, your coverage is for $100, and those glasses are $500 because you're really vain. You can pay the difference. Well, I'll get the $100 pair, but I need a blue light lens because I'm on a screen all day. Well, they'll cover $50 at $75. You owe $25 of that. Okay. Well, hey, did you want this OptoMap thing in case you start to have retinal blah, blah, blah? It's $75. It's not covered by your insurance, but man, it's really good insight if you need it. Well, you know what? I will do that. Or no, what? I don't need that. I won't do it, right? So you see that there's a layering that happens already in healthcare systems, right? If any of you have teenage children and you said, man, straight teeth would be nice, how much of that is covered by your dental insurance? Oh, if you're like, oh, I'd like white teeth, you can have them, but we're not paying for it, right? So this multiple layering of delivery of services is pretty normal. Physical therapists have been married to this concept of when you show up, everything's covered. Probably not a sustainable plan to move forward, right? Some aspects should be covered, absolutely, right? But there's a difference if somebody's coming to see me and they can't get out of their car, or somebody's coming to see me and they want to be a race car driver. Those are two different things, right? And some aspects, if you can't get in and out of the car because of your hip, I should be working with you, right? But I'm not here to make you a race car driver, right? Or the same thing, oh, I really need to be able to reach to put my jacket on. Yeah, we need to work on your shoulder. I really need to be able to reach so that I can have a better overhead serve. So I think that you're going to see this bifurcation that is normal, and we accept it in so many other professions. It's normal. Nobody thinks that your braces are covered. Nobody. Why do we then insist that we can't have a multiple layering or multiple level in our system? And it's again one of those things that we're kind of stuck in the mud over. We just kind of have to figure it out. We've got to get better at it.
Yeah. It's scary because it's different, right? I think we get accustomed to a certain way of doing business, and there's an inertia behind that way, and it's comfortable to let that ball keep rolling. But at a certain point, that ball's rolling towards a cliff, and you might not want to see what happens when it goes over, right?
And I will also say that, again, PT's not the only one looking at this, right? So I will make a shameless plug in the moment. In July, we're having a meeting in DC on the future of rehab therapy. And one of the things we're doing is we're bringing in the CEO of AOTA and the CEO of speech language of ASHA to kind of have these conversations about what are your pressure points? What is everybody seeing? Because we have to understand that This is not just a PT problem. This is a problem that our patients have. And a lot of our patients are seeing multiple providers, right? So you need to understand, well, just because they're seeing you, you also have to be part of the bigger picture, especially if you're going to assume the role of primary care or kind of leading the team or being in that larger doctoring level. You have to understand the bigger picture. And if we don't understand the entire landscape, then we're just focusing on the little minutia and we're not going to serve our patients the best we can.
I love it. It's not a shameless plug at all. I think for anyone who's listening to this, July 9th and 10th, down in DC in Alexandria, APTA's Future of Rehab Therapy Summit, an awesome event. I think for anybody who's interested in seeing where things are going, very, very excited for you guys to be putting that on. I think it's a fantastic example of leadership from APTA.
Yeah. Like again, right? It's about making sure we're putting our clinicians and the profession in the right role. And that's really what it's about.
Love it. Well, I think that is a perfect place to end this on. Drew, thank you so much for coming on today, sharing your learnings, your history, and like I said, as always, giving us the kick in the butt that we need on occasion.
My pleasure, everybody out there. Thanks for listening, and go out there and do your best.